So greetings to everyone. I'm Mokhsha Balakrishnan, Assistant Professor from Department of Psychology, Kristu Jayanti College, Autonomous. So today we'll be looking into the topic of trichotillomania. So it is a disorder that comes under the category of disorders involving obsessive compulsive disorder, hoarding disorder, and body dysmorphic disorder. So hair pulling disorder is usually, you can witness it along with another disorder called excoriation disorder. So we will look into detail about hair pulling disorder or trichotillomania. So your hair pulling disorder is a chronic disorder characterized by repetitive hair pulling, leading to variable hair loss that may be visible to others. It is also known as trichotillomania. So for an individual who is going through a hair pulling disorder, trichotillomania, you can visibly see them getting into the action of or involving themselves or exhibiting behaviors that involves them plucking their hair out compulsively. So the disorder is similar to obsessive compulsive disorder and impulse control in that there is increased tension prior to the hair pulling and relief of tension or gratification after the hair pulling. So what they mean in this sentence is that similar to obsessive compulsive disorder, there is a obsession, that is a set of thought patterns that makes them want to involve in a certain set of actions, and there is compulsion. In order to relieve them from this tension or gratification, they involve in a compulsive acts of behavior like pulling the hair. So diagnostic criteria. So the specific DSM-5 criteria for trichotillomania are as follows: recurrent pulling out of one's hair resulting in hair loss, repeated attempts to decrease or stop the hair pulling behavior. The hair pulling causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The hair pulling or hair loss cannot be attributed to another medical condition. So in the clinical feature of an individual who is diagnosed with trichotillomania, there are higher chances that the patient or the person with trichotillomania would have approached a dermatologist before approaching a psychologist or a psychiatrist. The hair pulling cannot be better explained by the symptoms of another medical disorder. Example, attempts to improve a perceived defect or flaw in appearance, such as may be observed in body dysmorphic disorder. Trichotillomania symptoms. So these are the pictorial representation of the symptoms and how it will look. Epidemiology. So the most serious chronic form of the disorder usually begins in early to mid-adolescence. The number of men may actually be higher. That is, the men who are diagnosed with trichotillomania will be in a higher frequency because men are even more likely than women to conceal their hair pulling. A patient with chronic hair pulling disorder is likely to be the only or oldest child in the family. A childhood type of hair pulling disorder occurs approximately equally in girls and boys. That is, occurrence of hair pulling disorder in the childhood has the same statistics between girls and boys population. An estimated 35 to 40% of patients with hair pulling disorder chew or swallow the hair that they pull out at one time or another. Comorbidity. Significant comorbidity is found between hair pulling disorder and obsessive compulsive disorder, anxiety disorder, Tourette's, depressive disorder, eating, various personality disorders, especially obsessive compulsive personality disorder, borderline, and narcissistic personality disorders. So to look into the etiology or the causes, there is a disturbance in the mother-child relationship or fear of being left alone, or recent object loss are often cited as critical factors contributing to the condition. Substance abuse may encourage development of the disorder, and depressive dynamics are often cited as predisposing factors. So for a person to develop the symptoms of trichotillomania, there could have been a history of substance abuse, or it could have even been the initiating factor of trichotillomania, as well as depressive dynamics could also be present. Family members of hair pulling disorder patients often have a history of tics, impulse control disorders, and obsessive compulsive symptoms, further supporting a possible genetic disposition. So here they're telling that an individual with trichotillomania symptoms could have a family history where the relative's first relative could be diagnosed with a history of tics or impulse control or OCD. Yeah. Diagnosis and clinical features. Two types of hair pulling have been described. Focused pulling, it is a use of an intentional act to control unpleasant personal experiences such as an urge, bodily sensation, or thought. For example, if let's say an individual is going through an intrusive thought and he has the urge to pull his hair out in order to channel that frustration somewhere. So that is enabled, or that is called as focused pulling. In contrast, automatic pulling occurs outside the person's awareness and most often during sedentary activities. Here, the person is not really aware that he is pulling his or her hair and not consciously engaging in this behavior. Rather, it is just a sedentary activity. Hair loss is characterized by short, broken strands appearing together with long, normal hairs in the affected areas. No abnormalities of the skin or scalp are present. So they don't really have a skin issue, that is, they don't really have to be prescribed to a dermatologist. Diagnosis and clinical features. Trichophagy, mouthing of the hair, may follow the hair plucking. So in most of the cases, you can witness the patient's mouthing of the hair, that is, they try to swallow the hair that they have plucked. Complications of trichophagy could include trichobezoars, a hairball that forms in the stomach of intestines, malnutrition, and intestinal obstruction. Patients usually deny the behavior and often try to hide the resultant alopecia. Alopecia is nothing but hair loss. Headbanging, nail biting, scratching, gnawing, excoriation, other acts of self-mutilation may also be present. Excoriation here means skin plucking or peeling of the skin. Differential diagnosis. As with OCD, hair pulling disorder is often chronic and recognized by patients as undesirable. Unlike those with OCD, patients with hair pulling disorder do not experience obsessive thoughts, and the compulsive activity is limited to one act, hair pulling. Whereas in OCD, the symptoms are quite pervasive and there are multiple symptoms that could come up. Whereas for hair pulling disorder, it is very idiosyncratically for just hair pulling. Patients with factitious disorder actively seek medical attention, and the patient role deliberately simulate illness towards these ends. Patients with stereotypic movement disorder have stereotypical and rhythmic movements, and they usually do not seem distressed by their behavior. Treatment plan. Treatment usually involves psychiatrists and dermatologists in a joint endeavor. Pharmacotherapy. Initial case reports showed efficacy of selective serotonin reuptake inhibitors, so SSRIs are quite effective. Successive behavioral treatments are necessary, like biofeedback, self-monitoring, desensitization, habit reversal have been reported, but most studies have been based on individual cases. So it's quite difficult to generalize it. Insight-oriented psychotherapy as well as hypnotherapy has shown effectiveness in the treatment of the disorder, but it must be explored further. Thank you.